Let's go ahead and get started. Good morning, everyone. My name is Sean Neal, and I'm the Director of Grassroots of the American Osteopathic Association. And I want to thank everyone so much for taking the time out of your busy day to join us for a health policy webinar on COVID-19 legislation. We know that your time is very valuable, so we are thankful that you would spend your morning with us, and we're honored to have Senator Cassidy be a part of it. And give me just 1 second here. Get to the controls. There we go. The COVID-19 pandemic caused many problems for our members and the patients that they serve. And the only way we could fully understand the magnitude of the problem and the issues physicians are encountering is by listening. So we created a Tell Your Story campaign to gather testimony to help guide our advocacy efforts. Some of the challenges identified by our leadership and advocates were shortages in personal protective equipment, medical liability gaps, and concerns about personal financing and keeping their practices open, just to name a few. We wanted to communicate these challenges and frustrations that our physicians and students were facing with Congress to help identify the full scope of the problem with them. So we sent multiple letters to the administration and Congress as they were crafting legislation to help combat the COVID-19 pandemic. We also know that it is important that our lawmakers hear directly from their constituents. We created multiple advocacy campaigns encouraging DOs to send their lawmakers an email expressing their concerns. We also encourage them to attend town halls when possible. And we know that our membership is extremely busy during these difficult times, so we wanted to make it as easy as possible for our osteopathic physicians and students to connect with their lawmakers. The AOA sent a grassroots advocacy alert to our membership this morning to call on Congress to address some of these concerns I mentioned earlier, such as financial relief and medical liability reform. But we are also calling on Congress to provide some paid family and medical leave benefits for our healthcare workforce that was already granted to others, as well as student debt relief for those medical students who graduated early to go on the front lines to fight the coronavirus. These grassroots campaigns were made possible through our Osteopathic Advocacy Network, and we're currently looking for more active DOs and students who want to engage in advocacy more frequently. So if you're interested, you can learn more at osteopathic.org/grassroots. With that very brief recap and summary of our advocacy efforts, I now want to pass it over to our very own AOA CEO, Kevin Clower, DO, who has been tirelessly leading this association through these difficult times for some remarks. Dr. Clower?
Good morning, and just confirming you can hear my audio?
Yes, we can hear you great.
Well, very good. Thank you very much for the great introduction. Well, it's my pleasure to introduce our guest speaker. The AOA is grateful to be joined this morning by Senator Bill Cassidy. Senator Cassidy was first elected to the U.S. House of Representatives in 2008 and to the United States Senate in 2014. Senator Cassidy serves on both the Finance Committee and the Committee on Health, Education, Labor, and Pensions. He has used his position on these committees to serve as a voice for physicians and their patients. I want to take this opportunity to express our gratitude to Senator Cassidy for his leadership and relentless effort to get policy right on surprise medical billing. Senator Cassidy is a graduate of Louisiana State University for both his undergraduate education and medical school, and was a practicing gastroenterologist in the Baton Rouge area until 2013. He is also no stranger to crisis management. In the wake of Hurricane Katrina, he led a group of healthcare volunteers to convert an abandoned Kmart building into an emergency healthcare facility, providing basic healthcare to hurricane evacuees. I know that Louisiana has been hit hard by COVID-19, with more than 24,000 confirmed cases. So we are very grateful to Senator Cassidy for making time for us this morning. Before turning the call over to Senator Cassidy, I also want to mention that we are joined on the call by a number of physician leaders in Louisiana, including the Dean of the Louisiana campus of the Edward Via College of Osteopathic Medicine in Monroe, Louisiana, Dr. Ray Morrison. Senator Cassidy, thank you so much for joining us today. I'll turn things over to you.
Hey, thank you. Thank you very much. And good to have somebody from Monroe, Louisiana. That's a brand new school. So thank you for everything you're doing. I have about 15 minutes. And so I'm going to hit some high points and maybe, if possible, take a question or two that might be submitted. Thank you for what you're doing, your frontline caring for patients. And I always appreciate it, but I think all of society now particularly appreciates. Let's speak about brass tacks. You guys have got to keep your doors open. What's going on with helping you do so? Well, one thing, a lot of practices qualify for the payroll protection plan. That ran out of money. Hopefully today, that will be refilled so that practices which have applied for that will be able to access it. Now, if you haven't yet applied, do so quickly, because although there's going to be, 250 billion added today, there's a lot of small businesses that are hurting that are going to be applying for this money. And I too think that you'd be wise to apply as soon as possible. And just to be clear, if you apply for this through the Small Business Administration and through your local banker, that which you use to maintain payroll, pay rent, utilities, or mortgage interest will be forgiven as a grant and will not be required to be paid back as a loan. Secondly, there's going to be a pot of money going out this week for healthcare providers. And this will be, the way this formula will work is that they will compare how much our country spent on healthcare in the same period a year ago and bring it forward to this point. They understand a lot of folks have lost a lot of money by canceling elective procedures, routine visits, etc., because of the COVID-19 and the need to marshal all resources to address COVID-19. So to the degree that you have lost income, you will have a proportion of that filled by the separate fund that is going out to all healthcare providers. The rules of this are being written, but I'm kind of describing as it is now. If you didn't bill Medicare, if you don't have a Medicare number, it's going to be a little bit harder, but they're going to come back on the back end to help those providers who do no billing for Medicare. But there will be a separate pot of money going out for facilities and for practices to the degree that you are losing income now relative to the amount of care you provided last year. Another thing we've heard is about the Medicare advanced or accelerated payment. It's a 10% interest. A lot of folks are saying, I just can't make that interest rate. We had a phone call last night. The doctor is in Congress with Mark Meadows, the president's chief of staff, advocating that that interest rate be reduced to 2% or so. It has to be paid back. It's coming out of the Medicare Trust Fund, but nonetheless, to make it 10% is really to make it onerous, if you will. Let me also mention about things that have been done. Hopefully will be help you provide care for your patients and might usher in a new paradigm about how we care for patients. Telemedicine, a lot of rules have been written to facilitate the employment of that. Formerly, you could only use telemedicine if you're the person you were caring for was, say, in a rural area and you were in an urban area. This will change those rules. That has been changed in response to this crisis to allow telehealth to be employed even across town. Makes total sense to me. One Friday night, my daughter looks at me, we're watching television. She says, I have a rash, Dad. I called a friend of mine, a dermatologist, using FaceTime, showed him the rash. He called in a prescription without either of us leaving our home. My daughter was, on her way to getting her rash rid by the next morning when we picked up the prescription he had called in. So there's no reason that can't be employed more widely. I think the rules being established to respond to COVID is going to help maybe change how we go forward. There's also going to be increased reimbursement for telehealth. Again, why should you have to leave your office on a Friday night, your home on a Friday night, if you can conduct your visit, if you will, over the telephone? Frankly, it helps the finances of your practice, but helps your lifestyle a heck of a lot. And most importantly, helps the health of that patient. One thing we've also been working for is the direct primary care model, where patients can contract with their physicians using their health savings account to pay for that contractual relationship. So far, I'm not being partisan, I'm just describing the state of play. Democrats have not cared for that. They think it's a bailout to concierge medicine, even though the rules make it clear it's not concierge medicine where somebody of high net worth pays $10,000 a year. Rather, it is kind of $150 a month paid to contract with somebody to care for their primary health needs. So far, Democrats have not been able to see the distinction between the two, even though the legislation has clear safeguards. Any advocacy you have along those lines with your elected representative would be good. And lastly, there's going to be greater concern for rural communities where clinics and hospitals might be further away. I should mention, by the way, there's going to be about $20 billion in the money Congress has appropriated that is specifically for rural healthcare providers. There's also specific provisions that we're advocating be applied to health service districts. Right now, hospital service districts cannot, which receive maybe a small amount of money from a tax base, have not qualified for anything. So we're also advocating for them to be addressed directly. Let me now take a couple minutes. I know I'm going quickly, but our time is limited. How do we off-ramp from this economic shutdown to where we can begin to reopen the economy, but still preserve the gains we've made against the novel coronavirus? I think we as physicians have got to advocate for applying science and public health to this problem. We know that there are folks who are at very low risk of dying from COVID-19 and at lower risk for having symptomatic disease. For example, if you're less than 49, you're at low risk. If you're less than 30, if you look at the data from Korea, China, Italy, and you're less than 30 and you got no underlying health issues, then you got about 0.2% chance of dying. And probably even that 0.2%, you think of that ophthalmologist in China at age 33 who died, he was an ophthalmologist. He was examining somebody's retina. He was in their face as they were breathing COVID-19 up his nostrils. So it may also relate to other factors which we can identify and protect against, which is viral load overwhelming our natural defenses. So I do think that we need to begin to stratify risk. It's going to take the medical scientific community to explain to the rest of society how this can be done. One way this could be done, for example, is by documenting immunity by who has an antibody or not. If COVID-19 is like other related illnesses, the presence of neutralizing antibody provides protection, at least mitigation, against future infection. So the documentation of who has antibody to novel coronavirus will be important going forward. Knowing who is immune is important for public health. So we use right now immunity registries, we call them immunization registries, but immunity registries in which we use a history of immunization as a proxy for being immune to certain diseases. Chickenpox, hepatitis B, measles, mumps, rubella, hepatitis A. All those are documented currently in immunity registries or immunization registries. This data is shared with the federal government through the Immunization Gateway. We can use the same mechanism to monitor who apparently has or who does have antibodies or would be immune to novel coronavirus and allow those folks to work more freely in society. For example, the nurse's aide who has antibodies could care for the routine patients without wearing personal protective equipment. That allows a little bit more freedom in our economy, but also relieves some of the strain upon the use of PPE. Same for doctors, nurses, the person at the front desk of the small business. All those things I think we have to think about. We also need to know who's immune, because those are the folks that we could get convalescent plasma from to use therapeutically for those COVID-19 patients who otherwise may not survive unless we can put in that convalescent plasma with those neutralizing antibodies to protect those patients. And lastly, I'll say we need to know who's immune, because there's going to be a vaccine that comes along sooner or later. We have 310 million Americans. If 80 million of us are already immune because of previous exposure with recovery, we'll focus our efforts on distributing vaccine to those who are not immune. Now eventually we may immunize everybody, but you want to focus your initial efforts upon those who are not immune. So there's lots of reasons to know who is immune, who is not immune. We as the medical scientific community need to communicate those ideas. Sean, let me pause here, see if there's any questions. I'm sorry to go so quickly, but I wanted to make sure I got through everything before we ran out of time.
Thank you so much for your time and your perspective. I'm going to go ahead and hand it over to Dr. Clower. I believe he has a question.
Hey, Dr. Clower.
Hello. Yes, actually, I'll defer to the field because there are a few questions that have come from the chat feature, and actually, I will hit the first one that I see here in the interest of time. So this one is coming from Dr. Kaczynski. The CARES Act funding needs to go to providers, not just hospitals, and needs to be based upon payment for all of our patients, not just Medicare. Our group staff, the Level 1 Trauma Center in Las Vegas, and as an urban center, has a much higher percentage of Medicaid and self-pay. Also, the CARES Act funding can't have restrictions like no money to people making more than the executive level 2 amount, $197,300. This prevents money from going directly to the frontline physicians taking their lives caring for the nation. So I will summarize the question and wondering, are there any provisions, Senator, to direct any of these relief funds directly toward the physicians, or any of the provisions addressing any of the components of the question of the statement made by Dr. Kaczynski?
Dr. Kaczynski, you got a lot in that question. Yes, but let me go through it in detail. This is not just restricted to those practices which see Medicare, but because somebody does see Medicare, the federal government has an idea of what your total book of business is. And so therefore that's, you're just on file, if you will. But I specifically asked Mark Meadows last night, the president's chief of staff, if you have an ambulatory surgical center, for example, in which 75% of their business on average is commercial, 20% is on average Medicare, 5% Medicaid, then will they get a proportion of their entire book of business, or just on that book of business, which is Medicare? He said on their entire book of business. And it will also go to physician practices, not just hospitals and not just facilities. So all that is good news. As regards the no-pay patient, there is going to be a specific amount of money to compensate providers 100% of their, I'm sure there's going to be some sort of Medicare fee schedule employed, but it's going to be able to compensate providers who are taking care of the no-pay patient. So if you're in Las Vegas, you're going to have a fair amount of people who are frankly undocumented, who are coming, and they need to be cared for. It's our ethic as physicians. And by the way, they still spread disease. And by the way, we're doctors. That's what we do. You will be compensated for that care delivered. Now, as regards a payroll protection plan, you did mention the restrictions upon the amount it will pay is $100,000, up to $100,000 of salary. So if you have a physician making $250,000 a year over the course of a year, the PPP will only pay up to $100,000 of that. Now, on the other hand, if your practice is getting compensated for the lost revenue relative to the book of business you did in a similar time period a year ago, obviously that's going to your practice, and you can distribute those funds as needed to maintain your practice. So I don't know of any restrictions on how that money is dispensed, and that could keep a doctor whole who's otherwise making more than $100K.
That is a great response to a complex but important question. If you have time, I have a little easier one for you here coming from David Walls. Would that be okay, Senator?
Yes, sir.
Senator, can anything be done to provide more equitable distribution of funds from the PPP program? Right now, companies that may not have had any impact from COVID-19 are receiving funds, while many practices that have basically been shut down are unable to receive funds. Is there any way to prioritize funds for those physician practices that desperately need the funds to keep their employees? So in part, the question has been answered, but this is more specifically targeted toward the specifics of the PPP, and I'm certain that David would appreciate a response. Thank you.
Yeah, great question, David. Again, as I said just now, all medical practices will benefit somewhat. When it comes to the PPP, the applicant was to attest that they have been negatively impacted. We understood when we passed this law that there was going to be a trade-off between being targeted and being speedy. And the more that you ask people to attest and to document that they had been injured, the slower the money would go out. So there was a request of banks to attest to the validity of what people were saying, but even that is not going to be hard and fast, and that was the trade-off. And we looked at each other in Congress and we said, we know there's going to be people who get money who shouldn't get money. On the other hand, if 5% of the money goes to those who don't need it, but 95% goes out in a faster fashion, helping people keep their doors open, otherwise not go bankrupt, well, that will be the trade-off we have to make. Folks are concerned about Ruth's Chris's getting $20 million. I get that, although in fairness, those are franchisees, so it is going to be an individual. In the aggregate, they're getting $20 million, but the franchisee in New Orleans or Las Vegas or New York is going to say, wait a second, I'm a franchisee, I'm not corporate. But still, you want that money to go to smaller businesses who have the ability to keep people on payroll, to keep families afloat as well as their business afloat. Hopefully, by putting this extra $250 billion in, that will help, in addition to the $350 that already went, that will help that happen. Dr. Claros, I have to sign off, but thank you for organizing the call. I appreciate everything y'all are doing to be frontline, to keep your businesses afloat. If there's any way I can serve you otherwise, please let me know.
Well, thank you very much for your time. And if you can please advise us of any legislative priorities that you have, we want to be a good partner with you and make sure we're supporting whatever you're trying to accomplish. Thank you so much for your time, and thank you everyone for attending.